We have simultaneous interpretation available into 3 languages: English, Spanish, and Portuguese. This means that you can participate in this webinar in any of those languages.
We have simultaneous translation into English, Portuguese, and Spanish for you to participate in this webinar. Well, maybe we'll give one more minute and then we will start with the agenda. Vamos a dar un minuto más para que los participantes puedan conectarse y empezamos con la agenda. Ok, listo, empezamos entonces. Buenos días a
Very
todos.
well, let's get started. Good morning, everyone. My name is Pamela Bravo. I'm a specialist in immunization, and I work in the immunization special program here at PAHO. I'd like to welcome you to this webinar, which is titled Between Urgency and Resilience, Culturally Aware Strategies to Address Measles Outbreak. The measles outbreaks we are now having in our region. We are joined by Dr. Daniel Salas. He's our executive manager at the Special Immunization Program. We're also joined by a number of expert panelists who will give us a general overview of the latest outbreaks. And they will also share with us some insights on culturally aware strategies that need to be taken into consideration. Finally, there will be a wrap-up session about communications by our official of communications. As we've mentioned earlier, we have simultaneous interpretation available into English, Spanish, and Portuguese. And both presentations and the recordings of this webinar will be uploaded in the relevant website, which will be shared in the chat so you can access to them if you want. Please, any questions that you may have, feel free to share them on the chat or through the Q&A function. Without further ado, I'll give the floor now to Dr. Daniel Salas, who can introduce us to the session. Go ahead. Thank you, Pamela, and welcome everyone to this very relevant webinar about current times we are experiencing. As you know, it is important to talk about outbreak control, and right now, measles outbreak control, taking into consideration a culturally perspective, because we cannot leave aside how cultural elements permeate a lot of the dynamics behind outbreaks or other phenomena. So it's truly a privilege to contribute to this relevant discussion, and especially be joined by Dr. Stephen Nolt. He is the director of Young Center for Anabaptist and Pietist Studies, and he's also a professor at University of Elizabethtown. Even though a few months ago we were an area free of measles, in the last few months, however, there have been some outbreaks in some countries, and so this reminds us that progress is not linear and is in no way guaranteed. These are epidemiological failures on the one hand, but they're also a sign that we need to strengthen trust in vaccination, especially in these times, especially too in communities where there's hesitation or some form of reluctance. We know that this reluctance to vaccination does not only spring from lack of information. Sometimes it's also driven by historical beliefs, experiences in institutional matters, or in legitimate concerns about safety and autonomy. So it's not enough to offer vaccination. We also need to build trusting bridges, and that requires a special ability. It's not only about being on the side of science, and just because we have scientific support, that means everything will run smoothly. In that context, Mennonite communities offer a unique opportunity because they have a strong cohesion at the social level and they have values that are deeply rooted. And so this requires and calls for a collaborative communication approach aimed at understanding and working together with the community from the heart of it. This is crucial so that healthcare services can be genuinely welcomed. The key to this is adapting our strategies, using reliable messengers within the community, offering clear and culturally relevant information, and ensuring that immunization services not only are accessible, but also acceptable from the perspective of those receiving these services. At PAHO, we are providing support to countries so that they can improve and strengthen their immunization programs by means of technologies such as geolocalization tools and other elements. But we're also promoting people-centered programs that acknowledge the cultural diversity we are immersed in. Also considering that cultural differences need to be tackled because this is part of the reality we have in many communities. Immunization is not only a medical intervention, it's an act of equity, social justice, and a commitment to collective well-being. Investing in vaccination is also investing in trust, resilience, and the future of our societies. And this message has never been more relevant than today. Let's remember that behind every decision, whether to vaccinate or not vaccinate, there's actually a story, a family, and a community. And it is in that environment and that family that there's understanding and a cosmovision. And that cosmovision many times decides and rules behaviors and patterns, not only about vaccination, but also about other elements and decisions. Our work is mainly to support. And in order to support effectively, we shouldn't judge. We should build together a road aimed at health for everyone and by everyone. Thank you for joining, and I hope you find this webinar useful and that it will prompt you to continue working with empathy, respect, and determination. Thank you, Daniel, for those welcoming words. Let's move on now to our agenda. Just a kind reminder once again, for those of you who are just joining this webinar, that we have simultaneous interpretation available into 3 languages, English, Spanish, and Portuguese. And also, the presentations and the recordings of this webinar will be available at the relevant event website soon. We are providing access to the website on the chat. Also, both via the chat and the Q&A section, you are welcome to drop your questions and comments. So without further ado, I will now give the floor to Álvaro Wittenbury and Gloria Ray. They are regional advisors for immunization at PAHO, so that we can address the first topic. Álvaro, Gloria, the floor is yours.
Hola, Pam. Si me confirman que pueden ver.
Hello, could you please confirm if you can see my screen? Yes, we can see it and we can hear you. Great, thank you.
Muy buenos días con todos.
Good morning, everyone. We have very important topics to address today, and we'll work this first part together with Gloria Ray. And while the presentation is written in English, I will give it in Spanish. Then we will share the material in both English and Spanish. Just as an overview, this is the content of the presentation. We'll take a look at the measles regional situation, the response to measles outbreaks, how ongoing surveillance activities are doing, and then finally some key messages. What about the regional situation regarding measles? As you may know, last year in November, the region was once again re-verified as free of endemic measles. This is because Brazil managed to control very efficiently the outbreaks that had been taking place. And then the elimination level achieved have been sustained. As you can see by the numbers here, we have information about the last endemic outbreak. And then in November, there was a new study that supported the fact that these levels were sustained. So these are the evidences in the region. As you may see here, this year, we have 5,678 cases. These are the result of outbreaks, imports that have occurred from other regions. But the special thing about these outbreaks is that these outbreaks generate long chains of transmission, especially in the United States, Mexico, and Canada. We're also seeing relatively significant transmission levels in Argentina, even though these numbers, 32, do not reach the others in the other countries. There have been 7 deaths so far, 4 in Mexico and 3 in the United States. So as you can see, the northern area of the Americas, this is the one that's most affected, even though there are some interesting numbers down below in the region too. This chart here shows the difference in the amount of cases this year compared to the cases we had in 2024 and 2023. Pamela and I evaluated this very recently, and actually the cases so far in the year is 24 times the cases in last year. So this is a major significant increase. And on the right, you can see the distribution of cases based on epidemiological weeks and per country. These are updated data up to last Friday, with updates up to week 21. These charts show case distribution as reported in the region. They are organized by age groups. And while it's true that a significant number of cases happen between 1-year-olds and 40-year-olds, the most of the risk or the predominant incidence is in this group here, from 1 to 4 years old. Then we see a progressive reduction towards the other age groups, but there's still some impact. As you can see here in the group between 30 and 39, the risk in people older than 40 is significantly lower, but it's still there. And on the right, considering sources of infection, we have a very small number of cases, this 1%, imported cases, then in red, import related, but we have a very significant chunk, 57%, where the source of infection has not been determined clearly. And so this may tell us that there's transmission that's sustained in the community or in the communities, especially in the countries where the largest outbreaks have taken place. So it's very important to identify these sources currently in yellow. Now, talking about vaccination status, we see here on this second pie chart that there's a big percentage of the people that have not been vaccinated or that do not know. And finally, by final classification, we see that most of the cases have been identified by using lab tests, but there's also a percentage, 21%, where the classification took place by the epidemiological link.
Como podemos ver aquí, en
As you
Estados
can see
Unidos, que es
here,
uno de los países más afectados
the
este
United
año, hay
States is one of the
1.088
countries that
casos
have been most
confirmados por
affected.
33
Here, it's over
jurisdicciones
1,000
estados en el
confirmed
país.
measles cases
Y lo que
in
estamos viendo en
33
las últimas
jurisdictions.
semanas es
What we
una
have been
aparente
noticing in the past few
disminución en el
weeks
número de
is that
casos,
there's
lo
an
cual nos
apparent
da
reduction in the number of cases, as
la idea
shown
de
in
que
this chart. And this gives
realmente
us the
ojalá estos
idea that
brotes que se han
hopefully
presentado
these
principalmente
outbreaks
en el
that have
estado de Texas y
occurred
Nuevo
mostly
México
in
y que
Texas
están
and New
relacionados a
Mexico,
comunidades
and which are
menonitas, pues
associated to
pareciera
Mennonite
ser que
communities,
están
it
yendo hacia
looks
su
as if they are
control,
now
¿no?
on the downrise.
37% de los casos
37%
reportados en el
of the
país,
cases
en el
were
país del
reported
norte son de
in
5 a
in the
19
country,
años, en el
and
grupo de 5 a
they
19 años,
happen in the group
seguido de
between
aquellos
5 and
de
19
del
years of
grupo de
age,
20 a más años,
followed by
32%, y en los
the
de
other
más de
group
5 años,
above
31%,
20,
¿no?
and then
12%
under
de los
5
casos
years of age,
hospitalizados,
30%. 12% of
22% de los
cases have
menores
been
de 5
hospitalized,
años, 8% en el grupo de 5 a
22% under
19,
5
8%
years of
medianamente
age,
a más.
8%
Este
between 5 and
91%
19 years
aquí
of age, and
claramente nos hace
8% in over
referencia a que la
20.
enfermedad pues es
And
más
this
grave
96% tells us that
este grupo en cualquier
96% of
caso,
cases
¿no?
were unvaccinated or
Tres
with
fallecimientos se
unknown
confirman,
vaccination
¿no?
status. And as we said, 3
96% de los
deaths
casos
were
sin
reported.
vacunación o
So,
con
as I said,
deficiencia de vacunación.
96% of the
Aquí
cases
podemos ver los datos de calidad
were
conforme han sido
unvaccinated
reportados.
or
La
unknown
tendencia siempre es al
in terms of
incremento en el
status.
número de casos.
This we
Y
see
están
the
principalmente
situation in
focalizados
Canada,
en la provincia de Ontario,
and most of the
así como en
cases
la
are
provincia de
located or
Ontario,
centralized in
¿no?
the
Aquí
area of
vemos la mayor
Ontario.
afectación. También,
And
de acuerdo a las últimas coordinaciones que se han tenido con las autoridades
based on the
canadienses,
latest
pareciera continuar
coordination
estos
efforts,
brotes muy focalizados en
these
comunidades
outbreaks
menonitas.
have been
Sin
very
embargo,
much
ya tenemos
focused
un total de
in
9
Mennonite
provincias
communities,
afectadas, ¿no?
but there are 9 jurisdictions in
71% de los
total
casos
that have been
relacionados a
affected.
este brote que
71% of the
inició en
cases are
octubre
related to
del
this outbreak,
2024
which
en Nuevo
started out
Brunswick
in October
y que
2024 in
luego
New Brunswick
se diseminó hacia
and
Ontario,
then
hacia Alberta
spread
y otras provincias
to
también del
Alberta and
país.
other Canadian provinces.
47% de los casos en el
40% of the
grupo de
cases
5 a
are
17 años,
reported
seguido
in
de los
the
de
age group 5 to
18 a
17
24
years,
años
followed
y
by
de los
a
18 menores de
26%
25
in
años con
between 18
25%.
and
La gran mayoría
58,
de los casos no
25% under
vacunados,
5 years. And
37%
then
fueron
95% of the cases were
hospitalizados
unvaccinated or with
en
unknown
ese
vaccination
periodo.
status.
Los datos no necesariamente coinciden aquí,
These
como
data
ustedes
do not
podrán ver,
necessarily
dado que esta es
coincide.
una
As you can
actualización
see,
de
there's
casos
a
que fue reportada a la OMS.
2,700
Este
on
es
the
el último
one
dato que
hand
estaba
and
disponible en
2,500 on the
octubre
other. But
de
this is because the
esta
2,500 was
enfermedad.
taken from the website.
En cuanto a México, otro de
As
los
for
países
Mexico,
principalmente afectados,
this is
el
one of
brote
the
comenzó
countries that
en
was also mostly
Chihuahua
affected. The outbreak
y
started
dentro
in
de comunidades
Chihuahua,
menonitas que tenían una relación muy
at the
cercana
heart
por
of
frontera con
Mennonite
Texas, pero
communities
además también
who
con
were
comunidades
very
menonitas
close to
en
Texas
Canadá,
through the
¿no?
border, but they were
Entonces,
also close to other Mennonite
este fue
communities
el estado
in Canada.
principalmente
So this
afectado
is
en
the
este listado
state
que tenemos a
that
la
has
derecha.
been mostly affected, as you
Bueno,
can see by the
94% de los
charts
casos
here.
del país
Um,
son de este estado, pero ya se han presentado brotes también en
but
varios otros
there
estados, en
have been
total
other
17
outbreaks
estados
in
del país.
other states too, in total
El único
17
estado en el cual
across
el
Mexico. The
brote no
only
está
state
relacionado a este
where
brote,
the
que es
outbreak
Chihuahua, es
is not
Oaxaca,
connected to
y
this
muy
Chihuahua
posiblemente
outbreak
estén
is
cerrando su puerta,
Oaxaca,
justamente se
actually.
deriva o se relacionó a otra
And probably this
infección.
outbreak is
Es de
attributable
preocupación,
to
por
some
supuesto,
other
lo que
source.
ocurre
This
además
is
en otras
concerning, of
comunidades, como
course,
vamos a ver
especially when
más
considering
adelante
what is
y viendo,
happening
por
in
ejemplo,
other
lo que ocurre en el
communities. As we
estado de
will see
Sonora,
later on, we will
donde la
take a look at what is
transmisión
happening in
ya se está
Sonora,
conteniendo, se está
where transmission
diseminando a
is
población
now
principalmente indígena rarámuri,
being
¿no?
controlled a little bit,
Esta es la
and it
distribución por
regards
grupos de edad en
indigenous
México
communities.
y
This is the
como pueden ver aquí
distribution
que
status in
principalmente
Mexico.
afectados el grupo de menor de
You
un
can
año de edad,
see
donde la tasa de
that
incidencia es
the
mayor.
group that has been
Luego la
most
tasa de
affected
incidencia va
is
cayendo por grupos de edad.
people
No
below
obstante, hay
and
un
under
número
1 year of age,
importante
and there's a progressive
de número
decrease.
de afectados
However,
en
there's
el
a
grupo de 20
significant
hasta
number of
40 años
people
de edad,
affected
por
in
lo
these two
cual,
groups
de
between
manera
20 and
fronteriza,
29
hemos
and
dado
30 and
referencia a los
39. This
indígenas,
is why
sobre
the
todo
country
en
has
las
been
zonas
recommended
de
to
Chihuahua y en
include,
las zonas más
especially in
afectadas de Chihuahua,
Chihuahua
con
and
relación
other
a este grupo
areas,
de edad para realizar
um,
actividades de vacunación
activities here
masiva
about
y accesible, ¿no?
immunization.
Vemos cómo también
We
es
see
importante mostrar
also
aquí que si
how
bien en
it's
un
important to
principio los
show that
grupos
although
indígenas
at
comienzan a
first the
comenzar
outbreak
luego,
starts in
a
Mennonite
partir de la semana
communities,
13 y hasta la
after the
14,
third
ya
week
los
and
otros brotes
14th
se han
week,
presentado por fuera de estas
the vast majority of cases are outside of these communities, and they are sustained in the general population in Chihuahua, the state where transmission is strongest. 79% of cases are reported in non-Mennonite population, which means that we have a sustained transmission in other communities, and therefore the risk is much higher. Argentina, we also have an important outbreak with 32 cases related to an import that arrived at Buenos Aires city. They are not related to the cases in the northern area of the continent. We see that the highest number of cases nowadays is in the province of Buenos Aires, then the city of Buenos Aires, and there are some cases localized in other areas of the country. This single case in San Luis province is the only one that's related to the Chihuahua outbreak from a Mennonite community, but luckily, coordination efforts with Mennonite communities are strong in Argentina, which is why they have strong vaccination coverage. So up to today, no significant transmission chains have been observed. But what we're seeing in Buenos Aires province and Buenos Aires city matches all of the characteristics of the little drip cases, meaning a slow and sustained pattern for transmission. I will now give the floor to Gloria Ray, our specialist in surveillance and laboratories, to carry on. Gloria, I give you the floor. Thank you, Alvaro. We will now move on. You can see the distribution of measles sequences reported to means. Means is an acronym which is basically the genetic sequence base of the measles virus presented by WHO. This chart goes from 2021 to end of May of 2025. Basically, this is color-coded. Each color represents a country that has reported cases. Right now, we're talking about 1,061 sequences reported by 8 countries. It is worth noting that basically we're talking about 2 genotypes that have been identified in this region. We have B3 and B8, and D8 actually. It's important to note that although measles has a RNA genome, it is a monotypical virus, meaning we have just one serotype. However, genetically, we have distinguished 24 genotypes based on the sequence of the gene that has to do with the H and N proteins. This is how we have identified all of these genotypes. As we can see, in the latest years, we've noticed a reduction of global circulation of these genotypes, and in the region, we've only identified the genotypes B3 and D8. In the lower side of this screen, you see the number of genetic sequences that have been reported by different countries. Regarding the cases that have been confirmed, we have the second line, and then the third line shows the percentage cases with sequences. From 2021, we had a growing trend, meaning the cases that had identified sequences were increasing, but lately we are noticing a reduction, and right now just 7.3% of confirmed cases have an identified genetic sequence. The next slide has to do, although it's a bit dense, but our colleagues at the office have really collaborated with us, and it shows the distribution of measles sequences of genotype D3. As we know, it's the most associated with this year's measles outbreaks that have been reported in this period of 2025. In total, we have 302 sequences that have been reported. If we see here to our left, we see like a histogram that shows a number of sequences reported by epidemiological week. Each color has to do with a different sequence identification, which is DSID, the acronym in English. This is assigned by the means system when the country or lab reports a genetic sequence. When there is a new report of a genetic sequence, and that genetic sequence is identical to a previously reported one, the system assigns it the same number. If the genetic sequence is different and has never been reported before, then the next consecutive number is assigned by the system. It's also important to underscore that when at least 50 identical sequences are reported in at least 3 different countries, that's when we start talking about a named strain. And when we talk about named strains, we mean that we have at least 50 sequences reported to the system, identified by at least 3 countries. In that case, the system assigns them the name of the first genetic sequence that was reported to the system. So we have an example of a strain called MVS, measles virus in English. Then it says Patan, the province, and then the acronym IND, which is India. The last numbers have to do with the year and the epidemiological week, which means that in 2016, for the first time, this genetic sequence was reported with these characteristics in India. If we see to our right in the first line, we have that in week 4 and week 5, countries of the region identified that exact same genetic sequence in imported cases. That's why it says Buenos Aires and also United States. However, I'd like you to understand that the fact that we identified genetic sequences does not necessarily mean that the virus that infected these cases came from India. This is just the denomination of the sequence, but it's important to note that the virus is circulating all around the world, and the case could have been imported from any other country, which is why it's important to track down the epidemiological data and compare it with the molecular information that is made in the laboratories to really fully understand these data. Okay, so now we will see an outline of the response to measles outbreaks. In that sense, we're going to focus on the vaccination tactics that have been implemented in the region to control measles outbreaks. We've identified practically 2 scenarios. To your left, you see the countries with community transmission and with long chains of transmissions that have been ongoing for weeks. In that case, the priority is to identify those higher risk groups and the populations that are directly impacted by transmission. The recommendation is mass vaccination. This means broad vaccination activities for the whole community, even with additional MR dose. To your right, you see the second scenario is countries with small chains of transmission, meaning they have a limited number of cases in areas that are clearly identifiable by their geography. The first priority is to implement vaccination, ring vaccination. That means vaccinating within the next 72 hours after a case and in a 5-block radius. And also, it implies following the route of movement during the transmission period. The next step is what we call mop-up vaccination. This implies conducting additional vaccination, and fundamentally, if vaccination activities are delayed, this vaccination activity has to be even expanded if we suspect that a transmission could have taken place. Finally, third step, we have the recommendation of rapid monitoring. And basically, this is really useful to identify those areas that need further intervention because we haven't reached all of the affected populations. We need to reach everyone who could be vulnerable in these communities. Although this slide focuses on the two scenarios that we have identified to control measles outbreaks, we want to remind you of how important it is to maintain high coverage, meaning in the countries that have had imported cases, then it's important to have strong coverage in the regular programs with all of the doses necessary, and also it's important to reduce the immunization gaps. That is, if there are children from 2 or more years old that haven't had their vaccines, it's very important to follow their vaccination schedule. Now we will delve into the surveillance response to control measles. And once again, we have two scenarios. Number one, we have the countries with active measles outbreaks. What we hope for in these countries is that rapid response teams are activated and rapidly incorporated to take all of the relevant control measures. It's also important to include all of the participants that are in the health system to have a coordinated response. The second recommendation is to implement a situation room, and it's important to have a situation room to carry out data analysis and decision-making. Depending on how the outbreak moves, the healthcare system has to be adaptable in its response to contagion chains. Number three, we have to incorporate and activate administrative measures that could facilitate the targeting of resources. We also have to remind countries that they can carry out a specific case definition. We have several cases, and if that happens, we can use a more specific case definition and document the time in which the definition changes to accurately analyze the situation. And that implies that the criteria for case confirmation have to include the clinical and epidemiological link criteria, which is why it's important that countries use these criteria too, and not just the lab confirmation cases due to the vast amount of cases that are being notified. To the right, we have the second scenario that comes from the point of view of those countries that don't have measles outbreaks or that don't have imported measles cases. If we start from the bottom, first priority is to strengthen surveillance. This is implementing active search strategies, especially in high-risk areas. And this is important to maintain high standard surveillance and to make sure that we can detect any importation early on. Number two is to adapt PAHO guidance, and adopt the PAHO's guidance. Number three is collect samples. In that regard, it's important to remember that out of every suspicious case, we have to obtain serum, nasopharyngeal swab, and urine samples from suspected cases to properly identify virus and genotype. With these samples, we can classify cases more easily, which is our fourth priority. We need to classify all suspected cases, and that classification has to be inclusive all the clinical, epidemiological, and lab information. Next slide, please. What we want to highlight with this next slide is how we can get to communities in risk before the measles virus does it. How we can outrun the spread of the virus, right, in these vulnerable communities. One strategy that we came up with is to have a tailored surveillance. We need to carry out monitoring of those areas that have low vaccination coverage to implement measures that can bring coverage back up. Next, we have communication. We're talking about tailored messaging. And this means we need to take into account a population's characteristics, so we need to understand our target communities. We also need to use effective tools, and within those tools, PAHO recommends micro-planning and rapid vaccination monitoring of vaccination coverage to properly identify if we're doing okay or if there's anything else that we need to do. And finally, we need to engage community leaders. This is fundamental. It's a key engagement to build public trust, not just with the public, but also especially about the vaccination activities. This map shows you the countries of the region where some of these communities are, those that have the highest measles cases lately. The darker the color, the more of these communities we have in each country. Next slide, please. Now we will talk about our surveillance activities. This slide shows the regional measles and rubella suspected case notification, at least this year. You can see how from 2021, the number of suspected notified cases is displayed. Remember that in 2021, we had the lowest number of cases reported to the system, and our region did not reach the notification level, but you can see that in 2024, 2023, and 2024, we see that we were able to record cases really well. If we see the cases reported until SE 20, we could reach and even be above the number of cases reported in 2024. However, if we move to the right, when we see how the distribution of MR cases have been, we see that there are some countries in which the fourth column, right, you see the red color? That red color means that for the week 20, those countries have not reported the expected number of cases. They're well below that. And the negative number means the number of cases that country needs to report to be with the expected levels. On the other hand, you see that we have some countries that have a green color, right? That means that for epidemiological week 20, many of them have even exceeded the number of cases to be reported. So it's clear that there are some countries that are doing really well. We could say they have a very rough, very solid, reporting system, but it's also important to reconsider that there are some countries that are still having a lot to do to intensify surveillance activities and looking for cases.
Let's go back to you, Dr. Alvaro Wittingbury.
Muchas gracias, Gloria.
Thank you, Gloria.
Entonces, para terminar, muy
Okay,
rápidamente,
to wrap up,
los mensajes claves.
let's take a look at key
Estamos en un
messages.
momento crítico.
This is a critical
Crítico
moment,
porque hemos
and it's
recuperado la
critical because
reverificación de la eliminación
we have recovered
y, por
this
supuesto, el
status
tema
of
principal no es
measles-free area
recuperar la
initially.
reverificación de eliminación,
And
más
of course, the
bien
issue is not to
sostener el
recover
estado de eliminación, porque sostener el
to
estado de
recover this, but
eliminación
the issue is really
representa
to
menor riesgo
sustain
de presentación de
an
esta enfermedad en
elimination
estas
status.
potencias. Entonces, hoy en día, las Américas como
Nowadays,
región
the Americas
realmente
as a
tenemos
region
la posibilidad real de perder
have
nuevamente el
a
estado de
real possibility
eliminación,
of
el
losing
logro de la eliminación si no
a
actuamos de manera
measles-free
rápida y
status and this
decidida, ¿no?
huge achievement
Y esto, por
unless
supuesto, va
we
a representar
react
un
quickly.
incremento del riesgo de
And
enfermedad
this would, of
severa,
course,
complicaciones
entail
de esta
an
enfermedad en
increase
nuestra población.
in
Y por lo tanto,
diseases
se
in our
requiere
population.
una respuesta rápida a
This
los
is why we
brotes
need a rapid
de
response
sarampión
to measles
a través de
outbreaks,
todos nuestros países.
and we need to do this
Sabemos que el
together through
sarampión
all of
se
our countries.
disemina muy
We know that
rápidamente
measles
en
spreads
comunidades,
rapidly
en comunidades cerradas, con una
in
baja
close-knit communities
cobertura de vacunación o sin inmunidad.
with low or no
Sabemos
immunity.
esto porque además el sarampión es la
And we know
enfermedad
this
más
because
transmisible que
measles
existe
is
y
the
no va a dejar de
most
encontrar hasta
communicable
última
disease
persona que no
ever,
esté
and they will
inmune.
leave no one behind,
Entonces,
really.
estas comunidades con esta reticencia a la
And so
vacunación
these
son
communities
las
that are
que se han
reluctant
mostrado
to
como
vaccination
aquellas que
have
principalmente han
proven to
estado
be
sosteniendo la
those
transmisión de la
that have
enfermedad en
been
nuestra región
reporting
durante este
sustained
periodo
levels
que
of
estamos
transmissions
analizando,
in a
¿no?
region in this period we are now analyzing, late 2024 and particularly throughout 2025. Delays in outbreak response and also the lack of proper coverage, together with the fact that many of these responses or coverage can be heterogeneous, they all increase the risk of sustained transmission throughout the region. In order to reverse this trend, we must deepen our engagement and we must also deepen our coordination efforts with vaccine hesitant communities. That means working hand in hand with local leaders so that we can deliver culturally appropriate education and thus promote vaccination and implement essential infection prevention measures, such as isolation if necessary. Finally, increasing measles and rubella routine vaccination coverage is key, both at the national and local level. And we need to understand that this is crucial, especially in communities where pockets of susceptible individuals remain. Of course, this entails ensuring the availability of vaccines, supplies, and human resources so that we can implement these actions and activities and so that we can protect our populations and prevent future outbreaks. The time to act is now. It is now, and based on the three components that are part of our sustainability strategy towards elimination, which we have been implementing so successfully so far for decades, we know that the time to act is now. High coverage in terms of vaccination, sensitive and timely vaccination and action. Thank you. Thank you. Over.
Muchas gracias, Álvaro, por la
Thank you,
presentación.
Alvaro, for your
Solo
presentation.
recordarles a los participantes
As a
que
reminder
pueden
to all
colocar sus
participants,
preguntas en
you
el
can
chat a
ask
cualquiera
your
de los
questions
panelistas.
through the
Y vamos a
Q&A
dar ahora
box at the bottom of your screen.
palabra al
Let's now
profesor
give the
Stephen
floor to
Nolt.
Professor Stephen Nolt.
Experto en
He's an
el
expert
grupo de los menonitas, en estudio de los
in
menonitas.
studying
Viene de
Mennonites,
la
in the group
Universidad
of
de
Mennonites.
Elizabethtown
He's
en
here
Pensilvania. Está
from
aquí con
Elizabethtown
nosotros para
College in
poder
Pennsylvania, and
ofrecernos
he's joined
algunas
us to
perspectivas
offer some
culturales e
perspectives, some
históricas de
cultural
cómo
perspective
podemos
and
abordar
historical perspectives
a
on how
estas
to best
comunidades.
address
Profesor,
these
por favor,
communities.
adelante con su
Professor, the
presentación.
floor is yours.
Thank you. It's nice to be with all of you, and me to share make sure I'm sharing my screen appropriately. Let me know. Okay, are you seeing just one slide?
Yes.
It's sharing correctly. All right.
Yes.
Thank you.
Just give me 1 second just to remind all our
Oh, sure.
participants that translation is available. Por favor, la servicio de interpretación al
Just a kind
español
reminder, we
y
have
inglés están
simultaneous
disponibles.
interpretation
La
available into
presentación
Spanish
del
and
profesor
Portuguese.
Nolt va a
Remember
ser
that
dirigida
Professor
en
Knoll's
inglés.
presentation
Las
will be in
diapositivas y su
English.
intervención también van a ser en
Slides and
inglés.
his
Entonces, por
intervention will
favor,
all be in English, so
hacer
feel free to
uso
tune
de
in
los
the
servicios
Spanish
de
or
interpretación.
Portuguese channel
Please,
if you need to.
Professor, go ahead.
All right. Thank you. Again, it's good to be with you, and my apologies that my Spanish is so poor. I need to speak to you in English on this topic. Given the time, I think I want to say a bit about the background and context, just very briefly, some of the variety, the perils of generalization when we're talking about Mennonite communities, and then briefly look at 5 broadly shared cultural values and characteristics that play a role in low immunization rates. And then we'll see what time we have for questions following that. So the first thing to underscore, and depending where you are, you know this, depending where you're located, but Mennonites are a highly diverse population. I just used some photos here from the United States of Mennonites some of whom are quite assimilated. Others are much more culturally conservative and traditionalist in their appearance, in their use of technology. So we have, for example, in the upper right corner, a Mennonite population that is still using horse-drawn transportation rather than automobiles, which would be the case of some of the Low German-speaking Mennonites in Bolivia, for example. And then also in the lower right corner, I included a photo of Dr. Joseph Martin, who is now retired, but was the longtime dean of Harvard Medical School and a big proponent of immunization. So there are Mennonites in North America who are involved in vaccine development. There are also Mennonites in North America who are resistant to immunization. And you would find some of the same dynamics across Latin America. If you go to Asuncion in Paraguay, there are Mennonites there who are involved in healthcare and the hospitals. Some of them have held ministerial positions in the government, but then there are also various colonies, as we saw in one of the earlier maps, of Low German-speaking Mennonites who I believe are really more the focus of your interest here today. So again, for our purposes today, I think the particular Mennonite group that's of interest are what we might call Low German-speaking Mennonites, who are primarily in Bolivia and Mexico and Belize and Eastern Canada, smaller numbers in Argentina and Peru and the United States, as well as Uruguay, Colombia, and Brazil. Not all of these Low German Mennonites are part of the same church denomination. And so even when we talk about just the Low German speaking Mennonites, there's variety within that group. So some of the most conservative members of this overall conservative group are known as the Old Colony Mennonites. There's also the Kleine Gemeinde Mennonites, Rhinelander Mennonites, somewhat more assimilated Mennonites that are all from this Low German Mennonite background that I'll get into in a moment. But these are just groups that are, again, at the more traditionalist end of the spectrum. You would have then again other Mennonites living in Bogota, in Asuncion, in Mexico City, who are quite assimilated and integrated into the professions and the economy and government and so on within Latin American states. But we're looking at the Low German speaking Mennonites who are much more rural. One key thing, I guess, to understand, given this is a Pan-American perspective, is that in Latin America, the Low German Mennonite groups are quite interconnected in terms of family and somewhat church ties. And likewise in Canada, a variety of Low German Mennonite communities that are connected to one another, some of whom are also connected to the Low German Mennonites in Seminole, Texas, in the United States. But one thing I would just mention here, because the outbreak in Texas has been so important, as we've heard, and has been central, it's important to note, and I'll show this on a map in a moment, that the group in Seminole, Texas, and it has an offshoot in Boley, Oklahoma in the United States, are very unusual in the context of the United States. These groups are actually not really connected to other Mennonites in the United States. They have a very different history and language, Low German language and church networks and family systems. They are actually more linked to Mennonites in Mexico and in Eastern Canada. So when we saw the maps with Chihuahua and Durango and Texas and Ontario, these are the places, for example, that are connected to one another in these networks. So just backing up a little bit about Mennonites, and we've heard the term Anabaptist. This is a religious tradition, a Christian tradition that emerged in the 16th century in the context of the Protestant Reformation. The name Anabaptist is a Latin term, and it referred to the fact that this was a group that practiced adult baptism in contrast to infant baptism. So the Catholic Church at the time and today practices infant baptism. The Anabaptists practiced adult baptism. And in the 16th century, that was illegal. So this was a sort of underground religious movement. There was no single leader. There was no state sponsorship. And so as a result, from the very beginning, there has been a diversity of Anabaptist groups. So it's not that there was a unified Anabaptist or Mennonite movement that then fragmented over time. Rather, this has been a very fragmented religious movement from the very beginning. Just to note that the name Mennonite is a nickname that comes from the name of one of the early leaders, Menno Simons, in what's now Friesland in the Netherlands. But he was not the only leader. He was not the first leader. There were many different leaders in different places, as you see on the map, mostly, though, in Western Europe. I said this was an underground movement, and this is an important part of the history and understanding their self-understanding. About 2,500 Anabaptists were killed in the first 90 years or so of the movement. And this experience encouraged a sense of separation from, as they would have said, the world, and they said a two-kingdom theology, separation of the church and the world, separation of church and state, and a suspicion of government and government intrusion in their lives. Again, we'll come back to this point. So by the 18th century, the 1700s, and into the 19th century, there is migration of many Mennonites out of Western Europe. Not all of them, but many. And there's sort of two streams. One, there's a movement westward across the Atlantic into North America, and that is the origin of most Mennonites in the United States today and some Mennonites in Canada. But for our purposes, the Low German speaking groups that we're focused on have a different story, and they move east, not immediately across the Atlantic to North America, to the Americas, but they move east into what is now Poland, and then into what is now Ukraine, and then on to North America, particularly Canada in the 1870s. Just to note here, the movement, the reason they leave Ukraine, which at that time was in the Russian Empire, in the 1870s, the Russian imperial government was instituting a policy they called Russification, trying to forcibly assimilate minority groups within the Russian Empire. The Mennonites living in what's now Ukraine did not want to participate in that. They wanted to keep speaking their Low German language. They didn't want to adopt Russian education, Russian language. They were pacifists and did not want to participate in the Russian army. And so they leave for North America and they move to Canada. And the Canadian government, particularly in the province province of Manitoba, promised that these Low German speaking Mennonites would be able to have their own schools, their own language, would be exempt from the Canadian military, and that they would be allowed to see to their own affairs. What happened was that during World War I, during the 1914 to 1918 time period, there was a strong wave of anti-German sentiment across Canada, also in the United States, but for our purposes, it's important that it was in Canada, because the promise to the Low German Mennonites in the 1870s, the promise from the Canadian government that they could have their own schools, speak their own language, was withdrawn. They were no longer allowed to use German and Low German. They could not have their own schools in that language. And so in the years after World War I, in the 1920s, large numbers of Low German speaking Mennonites left Canada and moved to northern Mexico, particularly to Chihuahua State, but then later into Durango and some other places. And from there, later in the 20th century, they moved to other parts of Latin America. Then in the 1970s, some of these Mennonites left Mexico to move back to Canada, not necessarily always back to Manitoba, which their grandparents had come, but most of them to Eastern Canada, usually because they were looking for economic opportunities that were more prevalent in Eastern Canada. The story of the Mennonites in Texas, who've been central to the measles story, is a very curious subplot to this story. In the late 1970s, one of the groups of Mexican Low German Mennonites who were moving to Ontario and received transit papers to cross the United States into Canada stopped in Texas and decided that they wanted to stay in Texas. And so there, I'll show in a map in a moment. It's a very unusual story, but it's one of the reasons that group in Texas is not really related to any of the other Mennonites in the United States. They are connected to the Mennonites in Mexico and Canada, but they were a group that was in transit from Mexico to Canada and just decided to stop in Texas. So again, these are the traditionalist, culturally conservative groups that we know as Low German Mennonites. And we usually use the term Low German Mennonites as an overall, overarching name for these groups, both because it does describe the German dialect that they speak, Low German, meaning from the north of German-speaking Europe, and also that the name Low German Mennonites is helpful because it reminds us that maintaining their German customs and way of life and language was the key reason they left first the Russian Empire and then Canada. So it points to that important part of their culture. The map here, which comes from a book that would be a great book, I suppose, for any of you to look at, from 2013 from Dr. Royden Lowen from the University of Winnipeg. Dr. Lowen is now retired, but this is a map that shows the migration of Low German Mennonites beginning in the 1920s out of Canada, moving to Mexico, moving to parts of Latin America, and then moving from parts of Latin America, particularly Mexico, back into Canada. And if you notice, there's really no arrow that's going into the United States, except the one short arrow that says 1970s that's going from northern Mexico into Texas and then stops. That's the group that was migrating to Ontario and just stopped in Texas. The other arrows that maybe look like they're going to Detroit in the United States are actually going to southern Ontario. The group that ends up in Texas, I won't go into a lot of detail here, but it's relevant in that the group was allowed to stay in Texas, allowed to stay in the United States through a very unusual set of political and legal circumstances in the United States, in which the U.S. government acted on a private immigration bill, which is very unusual, to allow them to stay in Texas. Unfortunately, this private immigration bill was often misunderstood by the Low German Mennonites as or I should say it gave the impression that one could kind of freely cross borders and the normal immigration laws didn't apply to them, which was not the case and is not the case. But this piece of legislation in 1979 set a bad example and has resulted in a lot of confusion in many Low German Mennonite communities about immigration law. So again, as I said, these are people who speak Low German. Many of them also speak English. They often speak Spanish. They vary in their degree of traditionalism. In Bolivia, for example, technology is restricted much more so than in other areas. The use of horse and buggy transportation, for example, dress is very distinctive. For those in Texas and some in Eastern Ontario, there is maybe distinctive dress, distinctive clothing, Low German language, but they're not as distinctive in their dress, and their use of technology is not nearly as restricted as one would find, for example, in Bolivia. Again, just a word, those who end up in Texas, it's in the county of Gaines County. Later, some families moved to Boley, Oklahoma, and to southwest Kansas. But again, otherwise, they're not connected to other Mennonites in the United States. I would note that my last 2 points, this story of migration from Ukraine to the Russian Empire to Canada to Mexico and to beyond is often understood by them as a story of identity, of fleeing state intervention. So their sense of leaving intrusive government is part of their own self-understanding. And the particular community in Gaines County, Texas, because they only arrived in Texas in the late 1970s, they missed out on the mid-20th century immunization campaigns in the United States that some other conservative Anabaptist groups in the United States did participate in. But the Gaines County, Texas, Low German Mennonites did not share that history at all. The other thing I guess I would note is that this is a young population. So in the United States, the census is not allowed to ask questions of religion, but we do have some other census numbers from some Latin American nations. So this is from 2022. There was a census of Low German Mennonites in Mexico. There were 74,122 people, and the subsample that included ages showed that 62% of the population were 20 years of age or younger. So we believe this is representative of many of the Low German Mennonite communities across Latin America and in Canada. They have large families, and it's generally a young population. So what are the issues related to vaccine hesitancy? So the first thing I would say is the Anabaptist faith tradition has never opposed immunization on theological grounds. There is no religious tradition or religious text opposing immunization. The tradition in all of these groups is to defer medical decision-making to the individual households. And yet, and this is one of these paradoxes to hold in tension. For Low German Mennonites, for culturally conservative Mennonites, religion is an inseparable part of their life and culture. And so everything that they're doing or not doing or thinking about, they're thinking about it in religious terms. So this is not a religious prohibition, and yet many of the way in which they live is grounded in their religious understanding, and so it's never entirely cut and dry, which is one of the challenges of working with this population. I realize that the Low German Mennonites are not the same group as the Old Order Amish. The Old Order Amish are a different conservative Anabaptist group in the United States, but I'm using just a few quick examples here from the Old Order Amish in the United States who share many of similar cultural dispositions to that of the Low German Mennonites, just to illustrate my point. This was an article from an Amish publication in 1992 that emphasized that it's not a church decision, but a decision for individual families. And yet, as you read the article, it's clear that they're thinking about this in religious terms. And so it sort of is a churchly issue, even though they're saying it's really a family issue. This was more recently in 2020, an Amish publication that in the context of COVID, in which the author acknowledges or says that every Amish person over the age of 50 has been vaccinated for smallpox. And yet, as time, at this time in 2020, it was clear that not very many Amish people accepted the COVID vaccine. So again, just to show the variation in kind of uniform acceptance of certain vaccinations, but then the context changes and there's more hesitancy later. Similarly, an Amish publication that illustrates an Amish business that was hosting a vaccine clinic in the United States, but we also know in that same community there were many Amish people who refused to participate in that clinic, even though it was being hosted by an Amish family. So, what are some of the broadly shared cultural values and characteristics that play a role in low immunization rate? If it's not as cut and dried as there's a religious prohibition, which there's not, but what are some of the factors? So 5 of these rather quickly. And these are not things that are peculiar to Anabaptist communities. These would describe other conservative, culturally conservative, perhaps more isolated or rural communities of various natures. But these are 5 characteristics I would name for the Low German Mennonites in Latin America. One is that they are a collectivist culture, and they have what we would say in English is a social posture of yielding. So collectivist cultures prioritize the group. They are often guided by tradition over the individual. And so there's encouragement to yield, that is to yield to God, to others, to the church, to tradition, to older community members, not to rush ahead, not to act individually, not to publicly stand out, not to go against the general consensus of the group. This means that change on all fronts happens rather slowly, happens organically, and it's much more of a communal process. So the social posture of yielding is expressed in more of an orientation to the group, a desire to know what the larger group thinks before taking individual action, a hesitancy to put oneself forward as an example or a model, reluctance to call attention to oneself by being named or posing for a picture. Before this webinar began, we were talking about the challenge of using photos and images. Even people who perhaps are okay with being photographed don't necessarily want that photo to be used in a public way because it calls attention to themselves. And in patterns of interpersonal communication, often a more quiet demeanor, pauses in conversation, and so on, that more so than perhaps in mainstream Western cultures. Yielding to others, we find a strong emphasis on patience, on waiting to understand, on not rushing, a sense of divine providence. So this is not fatalism, it's not predestination, but it's from their perspective, a rather profound acceptance of human limitations. And all of these things militate against a robust embrace of preventative care. They tend to encourage a more reactive approach to medical care. If I break my arm, I need to go to the doctor to have the bone set and a cast put on. But if I'm currently not sick, then there's nothing to do. I would wait until there's some sort of problem that is presenting itself. I think in light of time, I'm going to move on. Again, household discretion in medical decision-making is key. The influence of family, of parents-in-law is very important. And so sometimes the shots that you received as a child may be the guide that you take for those that your children should receive. And so in some of these communities, I say some, I don't want to overgeneralize, that's not good here, but we do see sometimes the phenomenon of partial immunization, in which some households will accept certain immunization and not others, because they are thinking about not immunization as a whole, but they're thinking about it in terms of tradition, in terms of vaccines that they have received, or perhaps that their parents have received, and those are the sources of influence that are greater than, say, the current medical provider who's recommending something in addition today. Third, a high context culture. So this is a term, again, you may be familiar with from a public health standpoint. But a high context culture is a culture in which relationships with people tend to matter more than relationships with institutions or organizations. In a high context culture, trust is invested in someone who you know, and you know their context. You don't know them, not you don't just know them because of their formal title or their formal training. You know who they are in context. You know who they're related to. You know what they do. You know if they are religious. You know their beliefs. You know their extended family. So you have a lot of context. When you have a lot of context for someone in a high context culture, that's where trust accrues, and it can accrue slowly. Someone who arrives building a relationship simply on their credentials, their educational credentials, their public office, an organization that they represent, it's much harder and slower for trust to accrue. Because there's not all that context around that person. That would be a low context relationship, would be someone whose relationship is based simply on their or narrowly on their credentials, on their professional credentials, their educational credentials, their organizational credentials. And so we can talk about the fact that it takes a long time to build relationships and to accrue trust. And then also in a high context culture, trust and the context is lost very quickly when there's change in staff, when the local face, the actual person or persons in an office or an agency or an initiative change. So having an initiative or an office or an agency that has a longstanding presence somewhere is good. But if the people who are working there change rapidly, that becomes a problem in a high context culture, because it's the people themselves more than the office or the agency or the initiative in which trust is invested. Neighbors as a source of influence. So the fourth thing I would mention, conservative Mennonites, Low German Mennonites, and again here I'll just use the Amish. I know it's a different group, but a sort of a parallel example. They have a strong sense of in-group identity, but most of them do have out-group relationships. Neighbors, co-workers, customers, perhaps drivers for the Low German Mennonites in Bolivia who use horse-drawn transportation. They would hire non-Mennonites to drive them longer distances in a truck or a van. The same would be true of, say, Amish people here in the United States who hire a driver. And so these neighbors, in some cases, are relationships of long standing and high context trust, even though they are not Mennonite. And in general, in North America, these rural neighbors have become more vaccine skeptical. That may not be the case in Latin America, but in the United States and Canada it is. And I just have a quote here from an article, a journal article about Amish vaccination in Ohio, in which it's clear that the decline in vaccination among the Amish in Ohio parallels that of non-Anabaptists in Ohio, in rural Ohio, who have become more vaccine skeptical and more resistant in the last number of years. And just to use one example, a troubling example, I think, but this was from the early days of the COVID pandemic. This was in February of 2021 when COVID vaccine was becoming available in the United States. And a number of medical doctors who were had long-standing trusted relationships with old order Amish, very culturally conservative folks, culturally conservative Anabaptists here in Pennsylvania. These doctors took out an ad in a conservative Anabaptist publication. You can see the ad here, and it was gently but directly encouraging immunization. And within about a month, another group, a group that opposes vaccination, not an Anabaptist group, not a Mennonite group, not an Amish group, just a secular anti-vaccination group in the city of Philadelphia, took out a counter ad in that same Amish publication. So what we see is that unfortunately there are vaccine skeptical groups that are seeking out Mennonites and Amish as allies in their efforts. So this is just something else to be aware of. That this may not apply as much in Latin America, I don't know, but it certainly is the case in Canada and the United States. That's making our work more difficult. And then fifth, I mentioned this earlier, but there is a distrust of state intervention in these communities. Again, these communities meaning the culturally conservative, Low German speaking Mennonite communities. As I mentioned, Mennonites are a varied group. There are some Mennonites, again, in Paraguay who have been involved in government, who've held ministerial positions and who work for the government in Paraguay. But if we're talking about the culturally conservative, Low German speaking Mennonites, this is who I mean, a distrust of state intervention in their communities. There's this legacy of persecution, keen sense of separation of church and state. They refer to as a two-kingdom theology, the kingdom of God, which is to avoid civic responsibility, and then what they would call the kingdom of this world, which functions via coercion and violence and tends to claim more for itself than it should. So this is also part of the context in which we find ourselves. So just a couple of the questions that were asked, and then I need to turn it over to the next person. What are the most common activities that facilitate the movement and interaction of Mennonite communities across national borders? Again, it depends on which Mennonites one has in mind, but among Low German Mennonites, it would be family visiting and connections, and also work and employment seeking. Who's responsible for making healthcare treatment decisions? Generally parents and family members, household decision, but within this culture of yieldedness, it's also the broader community, and this is where the influence of the larger church community indirectly but importantly comes in. So I think I will end. I will include some other resources here that you might look to later when I upload the slides following the presentation.
Thank you, Professor Stephen Nolt. I think it was a very comprehensive presentation and provide very good insights in terms of the Mennonites communities in Latin America and in general in the world. I don't see any questions in the Q&A box. So maybe I will just ask one question before giving the floor to Beatriz. And it's related to the trust sources that you were mentioned. And that's something that we have observed in the approaches for our countries to contain the measles outbreaks. So will you recommend that we should look for those trusty sources that might not necessarily be someone from the government, but maybe someone that has established a close relationship with the community? For instance, someone that is connected to selling the products, because Mennonites in some of our countries are dedicated to agricultural activities, dairy production, etc. So maybe those people might be the bridges that we needed to deliver adequately our messages. And then the other question is related to what will be your recommendations to frame the messages to them in terms of incentivize the demand for vaccination. If you can also elaborate a little bit, whether we need to do it in Low German, whether we need to use English or Spanish, whether these cultures, these people read Low German or is more an oral language. If you can provide some insights on that, that will be also great before we move into the next speaker.
Okay. So these are great questions. They're also big questions, but I'll try to be brief. So in terms of trusted sources, yes, I think I wouldn't say that public health experts from the government should not be involved, but that's probably insufficient in itself. That's because it's a low context relationship. Finding trusted voices and individuals who already have those longstanding relationships, and they could be commercial relationships or connections through people who have business relationships. In some countries, Bolivia comes to mind, there is an international development organization coming from Canada that's known as Mennonite Central Committee. And it's possible the people who work with Mennonite Central Committee are not they are more assimilated professional Mennonites, not so it's a different kind of Mennonite, and those individuals, that is, the Mennonite Central Committee individuals, might not be the trusted sources, but they may be a good resource for helping to identify those resources, those trusted voices. And so that would be the case certainly in Bolivia, in Paraguay, perhaps also in Mexico. I'm less sure about Uruguay and Brazil. The question about language. So in general, Low German is a spoken language. It's everyone's first language, meaning it's the primary language that children learn. It's the language of the home, but it is primarily an oral language, a spoken language. Low German Mennonites also learn a standard German in their schools, but it's of a fairly limited vocabulary. The standard German that they're studying and learning has a limited, often more religious or historical vocabulary. Low German has a wider vocabulary, but it's against mostly an oral language, so it's difficult to put things in print. And so Spanish or English in terms of print materials I would say use all three: standard German, Spanish, and English. Again, different colonies in different countries are going to vary in how well standard German was taught, how much English has been passed down from their now great grandparents who came from Canada, how much there's been an assimilation to Spanish. That's going to vary from one colony to another. So you probably have to take a fairly community specific approach there.
Okay, thank you. We do have a question from the audience. It says, for some Low German Mennonite communities that have adopted modern technology, there seems to be a huge dissemination of conspiracy theories on social media. How can this be approached? It's a combination of the technology.
Yeah. So yes, this is a real phenomenon, and it's not unrelated to the print example that I showed earlier from that Amish publication in the United States. So I don't know that I have I don't have an easy recommendation for this. When you have a community that is I don't want to overstate this. So I don't want to overstate this, but when there is something of an inherent distrust of quote unquote the world and of government, I think that makes them more credulous when it comes to these kinds of conspiracy theories. And one might say, well, why aren't these non-Mennonite conspiratorial voices also, regarded as part of the world that should be suspect? But I think the way to understand this, obviously not to legitimate it, but to understand it, is that they have, that from their perspective, they have a 500-year history in which they, as a minority, have been misunderstood, and in their understanding, the truth has existed in minority corners, minority voices, minority communities. It's been the majority, the governmental majority, the demographic majority, the economic majority, whatever you want to say, that has that ran them out of Western Europe, that ran them out of the Russian Empire, that they saw as running them out of Canada. And again, we might critique that the accuracy of that historically, but their sense of self-perception highlights the makes them sympathetic to minority and unusual points of view, because they see themselves in that position. So yeah, I think it's a very difficult challenge.
Mhm. I have a couple more questions if my colleague Beatriz allow me, and that it's not common to have Professor Nolt with us. Another question that is coming from Mexico, actually from one of our professionals in Pajo, Mexico, is when you want to address health or immunization topics with the Mennonite community, will you suggest to deliver or these messages to women or men within the Mennonite communities?
I think it's appropriate to do both, but I think it would be you would probably want to use women speaking to women and men speaking to men when possible.
The other question is, sorry, I'm trying to, yeah, Colombia, if you are aware in what areas in Colombia, the Mennonite communities that are in Colombia, if you know what are their position towards vaccination, if
I'm sorry, I don't off the top of my
Mhm.
head. I'm sorry.
It's fine. There's another one, and I think we're going to close with this one. Where is the limit of government intervention to immunize the Mennonite community when measles threatens the rest of the population, especially infants who have not received their vaccine?
So the question, what is the limit? Meaning, at what
There's
point?
limited, yeah, up to what point? I guess this is related to whether government should be enforce certain policies to immunize the Mennonite communities when they reject vaccination, given
Mhm.
that measles might threaten other vulnerable populations,
Right.
if you have any thoughts on this.
Yeah. Hmm. Well, I mean, so actually, this is something related to one of the earlier questions, talking about messages and how might one appeal to Mennonites. Of course, every person is going to be different. There are different personalities and different communities, and it's difficult to generalize. But I do think an appeal on the basis of Christian charity, of concern for neighbors. Not saying that will work in every case, but that sort of approach, that part of that as a message, could be useful. Certainly, there have been cases of government enforced measures that has in some cases just resulted in outmigration and Mennonites leaving an area, and in some cases putting up strong resistance. In general, as a pacifist group, they are not going to put up a violent resistance,
Mhm.
but and they're not probably going to resort to use of courts or the legal system. Rather, they will just either withdraw literally by leaving, or just withdraw and become increasingly more insular.
Mm.
So the idea of enforcing immunization may be, in some cases, may be necessary. It should be done with an awareness that it may make the next round of engagement much more difficult. And so I suppose the trade-off is,
Mm.
what is the benefit? What's the benefit, cost benefit for a forced a vaccination campaign and the benefits of that, versus then the costs later of whatever the next round of public health conflict may be.
Great. Excellent questions and excellent responses, Professor Null. Thank you so much for your participation. I'm just going to give the floor to my colleague, Beatriz Velasco, our specialist in communication. So Beatriz, please go ahead with your presentation. And if people in the audience has more questions, please place it on the QA and we will try to answer them written or later on. Thank you.
Gracias, Pamela, y gracias al profesor, porque la verdad es
Thank
que
you,
ha sido
Pamela,
un
and thank
placer
you,
escucharlos,
Professor.
conocerlos
It's
mejor a la
truly been
comunidad
a
menonita y desde
pleasure
luego
to listen to you and learn so
abierto
much about Mennonite
las
communities.
preguntas otra vez a él o las que me quieran
And
hacer a mí, porque creo que este webinar,
please feel
la
free to
base de los
ask questions, whether to the professor or to myself, because the goal of this webinar really is to gain deeper knowledge about Mennonite communities and how to address our work and gear our work to them. So, as we've been seeing throughout Professor Knoll's presentation, human beings are complex. We live in a diverse world, and the Mennonite community is also a very diverse one. So we need to approach them with a sense of curiosity. I think all of us here share that sense of curiosity already. So it's important to highlight that, bearing into consideration the enormous complexity around the world and around human beings, we cannot just say to someone, you need to get a vaccine. We also need an evidence-based plan. This is very obvious, right? Because there's low coverage. We shouldn't just follow our instincts or prejudice about what someone feels or thinks about vaccination. And we should not repeat or replicate general communication campaigns, because pretty much that's been done since time immemorial. And so we need to go the extra mile and customize communication campaigns. As we've seen today, this is very important. Very quickly, I'd like to share with you some ideas. There's methodology through that PAHO has been studying, and that has to do with what drives vaccination acceptance. There are multiple factors. One of them is thoughts and feelings, meaning what people think about the risk of disease associated to it. And in the case of measles, even though we don't see that many cases nowadays, there's still a risk of disease that people may perceive. And so that needs to be part of our messages. Under this category, there's also an element of trust in vaccinations. And so this covers perceived advantages, safety, and trust. And as the professor mentioned, this also deals with what the Mennonite community thinks about vaccination. Not only this community, but also other countries too. And so this is important to bear in mind when you're designing a communication campaign, and you can really take into consideration what each audience deems relevant. Another important element is motivation. As the professor pointed out, many times there can be acceptance towards some vaccines, but not others. And so different factors need to be taken into consideration. And then last but not least, for sure, comes the element of practical aspects, meaning availability of vaccines. Sometimes people don't get vaccinated just because they don't have time to get vaccinated. Or sometimes they don't get vaccinated because healthcare staff have their own prejudices, or I don't know. I'm sharing a lot of information and very general examples that do not necessarily apply to all communities, but we as healthcare workers need to take all of this into consideration when designing a proper communication campaign so as to drive acceptance. So based on this methodology, a number of studies have been made. PAHO specifically has conducted several studies across the region in Argentina to explore, for instance, the level of acceptance of vaccines of COVID. also to study other types of vaccines and their acceptance or reluctance levels, etc. But all the activities we've conducted have showed us that the healthcare worker remains the most important person in the sense that they serve as source of information. And so keeping healthcare workers informed, not only about vaccination techniques, but also about communication is important. And they should also be informed about the particularities of each community. Depending on all these factors, and after analyzing them, we've identified a number of interventions that drive vaccination. If the problem detected has to do with thoughts and ideas, then communication campaigns should aim to inform or educate the audience about what vaccination is, what the disease at stake is, etc. And some strategies that may work are dialogues, expert exchanges, etc. If, on the other hand, the issues have to do with social processes, then we need to work on community engagement, meaning offering maybe more tailored messages tailored to that community. And finally, if the issue has to do with practical aspects, then what needs to be done is to maybe reduce pocket expenses, improve quality of service, etc. And actually, all these factors could happen at the same time, or two of them could happen at the same time. But this is why the response needs to be very specific to each case. I'm sure most of you know what a risk communication plan is, but I just wanted to highlight that designing a risk communication plan is important every time we tackle an endeavor of this nature. And for that, we need to think about, number one, what key messages? What key messages do we wish to convey? Maybe with the Mennonite community, we should convey messages about empathy, respect, messages that will appeal to community values and collective responsibility. And also talk about the risks of measles. Then we need to think about who we are addressing this to, meaning the audience. We as an organism or as an entity need to take into consideration primary and secondary audiences, meaning community leaders, people who have some level of influence in the communities we are, and the primary communities we're aiming to reach. These audiences need to be studied thoroughly and leave no one behind so that we can actually get to the target audiences we aim for. Number three, how, meaning supplies or materials. Based on the what and the who, we need to figure out whether we need printed material, digital materials, audiovisual materials. And even though we know that Mennonite communities may not be so reliant on technology, we do know that some of them are somewhat influenced by technology and actually use them. There's actually a Mennonite influencer, for instance, who's also a content creator. So this is something we need to take into consideration as part of our communication plan. Audiovisual materials typically work very well. Storytelling is important here so that the communities can feel represented and engaged with the content of the message in the context of this communication plan. And finally, we need to think about channels. Whenever we talk about communication, we always think about mass media outlets, right? Newspapers, radio, TV. But there are other media outlets too, maybe bidirectional channels. And these are materials or channels for which different materials can also be created. And All throughout this communication plan, we need to be mindful of practicing active listening, monitoring, and assessment, because we need to keep an eye on what we're doing. The evaluation element is important too, because we always need to learn from our experience for the future. This is a tool that can really help us get to know our audiences. I'll share this slide with you all. But sometimes it helps to put ourselves in the shoes of the person we are aiming for. Meaning, try to empathize fully with them. Who are they? What do they do? What do they feel on a daily basis? Are they parents? Do they have a very demanding profession? Are they very stressed? All these ideas and questions on the screen can help us fine-tune the message. And as I said, bidirectional channels work very well. And here are some examples. Knowledge exchange, community leader participation sessions, vaccination points that are accessible to everyone with trained personnel, trained in these communities in particular, information sessions in small groups. And in some cases too, for these communities, it's important to perhaps identify prominent profiles on social media in case we can find an influencer that can help us in the process. To wrap up, I wanted to show you some examples connected to messages and campaigns that have taken place in the context of this outbreak. Associated Press made this video in March, and one of the president of one of the Mennonite colonies was shown here, and he's a leader that is very much respected and trusted by his community. And so his appearance in this series of videos really gave a lot of reliability to the campaign and to the vaccines itself. And the same goes for this story here. This is a real story of one person who was infected with and was part of the Mennonite community. And, at the end of the day, we all love stories we can empathize with and relate with. Then, when it comes to PAHO, there's a department that works with social determinants, and they've done this intercultural dialogue sessions, as this article tells us. And the idea here was to maybe tackle perceptions, what each one felt. And as you can see, this is yet another example of what good engagement is and what getting closer to someone is.
Another example is that we could maybe create messages considering that they're Christians. This is a generalization, but we have these PAHO guides that are for free and contain examples on how we can respond to different questions and queries that they might have. And there was recently research of what media Anabaptists use. They do have specific Anabaptist media, as you can see in the slide. And there's also a World Mennonite community that has its own website. And actually, one of the messages was love neighbors, share vaccines. And of course, this has to do with community sharing and how you don't have to harm the people you know. And to your right, actually surprised me was I didn't know that you actually had Mennonite influencers. Marcela Enns is an influencer that has about 350,000 followers on social media, and she talks about a day-to-day life of Mennonites, and that is a challenge that you might be channel that's interesting to watch. Another example is the message from religious leaders from Canada to communities. We also have messages from the late Pope that had to do with vaccination. We also have podcasts, Tahoe podcast. We have interviews of professionals that clearly explain what measles is and share valuable information, because people always enjoy having clear, transparent information. And last but not least, as I said, we had debates where we talked about how it's not that easy to use pictures of Mennonites that easily. So we did a very, very simple carousel that portrays the importance of taking care of these communities, and that can actually make a big difference. And we highlighted the risk posed by measles. It can cause pneumonia, brain damage, among others. So with that, I want to say thank you. I am eager to answer any questions. Thank you, Beatriz. We actually do have a couple questions in the chat. I'd like to ask you to please respond really briefly. What do you mean by bidirectional channel and knowledge sharing? And that will wrap up. Thank you. So what I mean by this two-way channel is a channel that we can use, like, for example, social media, television, radio. That is not very conversational, right? It's not very two-way. What we're talking about is actually having a dialogue with people, with healthcare workers, when they talk to patients. We, as communicators, can gather that information and get that feedback. So that's what I mean when I talk about a two-way channel. In the Mennonite community, it might be a bit harder because not everyone uses technology. But for example, we have social media or WhatsApp. Those are good examples of what I mean. Of course, not all communities have it, but there are some that do use these examples of channels that we have to bear in mind. Thank you very, very much. So with this, we wrap up today's webinar. Once again, I'd like to thank all of you for your participation, and especially to our panelists, Alvaro, Gloria, Stephen, and Beatriz. I'd also want to give a big shout out to Victoria and Fernando, who are in the immunization team that are always supporting us in this Zoom webinar. We have left the links to the webpage of the event in the chat. And we also, we have the links that Juanjo Vasquez has sent. And either today or tomorrow, we will be uploading all of the presentations that you have listened to today in both languages, English and Spanish. If you have any more questions, please send them to inmunizacion@paho.org, and we will be responding them. And last but not least, I'd ask Beatriz and Professor Stephen.
Turn your camera. So Fernando, if you can take us a last photo of this event. And thank you so much, Professor, for your insights and knowledge delivered today. Entonces, Fernando, si nos puedes apoyar con una foto y si no la...
Fernando, let's take a picture.
Está lista, gracias.
Ah, ¿ya está lista?
Ready? Okay.
Muchísimas gracias.
Thank you very much, Fernando.
We'll be in touch. And grateful to have you here today. Para todos los demás, muchísimas gracias y que tengan un...
Thank you very much. Have a nice afternoon. Goodbye.
Muchas gracias. Thank you very much. Tengan muy buena semana.